Okay, I think we're going to get started. Hello and welcome. I can see that some old medical school habits die hard, so people are still lining up in the back row for your talk. My name is David Hayden. I'm a general internist here and one of the co-directors of our humanities lab, trying to integrate humanities into the medical school curriculum and into the medical center. But this is an event that we haven't had for a number of years due to something called COVID. And so it's so nice to see a group of people gathering. And we're going to hear Mark Vonnegut, and let me tell you a little bit about him before we ask him to speak. But I should actually thank Regina Reboyne from the library, who was really instrumental in getting this organized and getting this space and arranging for much of the reception, and Martha Wright from the Worcester District Medical Society, and this year's president, Giles Whalen, just walked in as well. So this is really a great event for them to sponsor, and it's nice to see such a crowd here because we don't see crowds anymore. So Mark Vonnegut is a pediatrician. He's helped children and families for the last 40 years. He grew up on Cape Cod, attended Harvard Medical School, where he graduated in 1979 and completed his pediatric internship and residency at the Mass General Hospital. He's practiced pediatrics for over 35 years, sometimes treating his patients from birth through childhood and adolescence, and later providing pediatric care after the births of their own children, which is a wonderful generational opportunity. Dr. Vonnegut published an article in the New England Journal of Medicine entitled "Is Quality Improvement Improving Quality?" And I expect for those people who are practicing, it's a question you've asked yourself many times. The rest of the title was "A View from the Doctor's Office." He's published several short pieces in pediatrics and other topics in the Globe and the Patriot Ledger. He's also published a number of books, The Eden Express, first published in 1975. And here at UMass, we have physician competencies, and two of those are the physician as professional, which places often lead with, and the physician as person. Mark reversed that. He wrote about the physician as person and then the physician as professional with his last two books. The physician as person was just like someone without mental illness, only more so, that he published in 2010. And his latest book is The Heart of Caring, A Life in Pediatrics. And that was released in February of 2022. In his latest book, he weaves together personal stories with larger trends in which many of the traditions of medicine are being lost due to the ongoing corporatization of the American healthcare system. He's passionate about the developmental and behavioral health as an integral part of primary care pediatrics. And he says practicing pediatrics has been a joy and a privilege. And that's something that we all want to remember. So we have now the privilege of hearing Dr. Vonnegut read from his book and talk about it, followed by a Q&A session and a book signing with more refreshments after we hear him speak. Welcome, Mark. I did.
Okay. Thank you so much for having me here. I love talking to people about things I care about. And for me, being a doctor was an amazing privilege. Being a primary care pediatrician in the same community for over 40 years has also been a wonderful joy and privilege. And my book is sort of like a love letter and to my teachers. And it's sort of also to the next generation, because I fear that the next generation of doctors will not have the same opportunities I've had to stay in the same community for over 40 years and take care of children. And I have hired one of my patients as a carpenter. He's taught me a lot of carpentry and taken care of his kids. And say, Jake, take your damn medicine when I see him on the job. Anyway, so I want to talk about patients, because that's what matters. And we hear about value-based medicine, and if it's not valuable to your patients, it's not valuable. You know. So my first patient as an intern was a 9-year-old girl who had a note, flew into Logan Airport, had a note pinned on her chest that said, "I have cancer, take me to Mass General." She also had a manila envelope with chest x-rays that showed all these horrible ping pong balls that I know what it meant. I knew that this girl was not going to survive. But there was something about, she was, without question, got all the best care in the world. It was free. And I think that was of benefit not only to her, but to Mass General, to science, to teaching me how to be a doctor. And I think if we don't take care of people who need care, what do we have? We don't, the profession is not really worth very much. But I just remember this girl with her mother by her side, holding hands, and I was there, and chief of anesthesia was there, and this was a girl with no money, nothing. She said, the note said, "My mother is coming later." But that was all available to her. And in those days, a hospital bed cost a couple $100 a day, and it was easy to give that away, and we did often. And now we go from giving away very complicated, complex care where orthopedics was involved, oncology, all that, to having to write prior authorizations for things our patients know, and we know that they know that they need. One of the things we learned in medical school was when to ask for help, and we know when we need help, and we can ask for help. And the idea that performance metrics, prior authorizations, co-payments, deductibles, enhanced reimbursement, that any of this helps patients it doesn't. It just plain doesn't. If there's anybody in this room, Dan, who finds the performance metrics and being told how to take care of diabetics, has this been helpful? Right. And the asthma started with the asthma QI, which is what I wrote that article, New England Journal. And any pediatrician who is helped by those guidelines of how to deal with asthma should not be practicing medicine. I mean, it's just so. And we were forced to go to, I remember a meeting, but the idea of doctors being forced to go to meetings rather than deciding which things are actually helpful to them. But I was told by people in shiny shoes and skinny pants that reactive airway disease was no longer a disease. Everything was asthma. Asthma was a chronic disease. So I was being told things that I know are untrue, but they had the power to tell me what I could diagnose and what I couldn't diagnose. So we have lost power. We have lost support and resources that are necessary to practice good medicine. Most medical care now is delivered by doctors, NPs, PAs, and even pharmacists now who have never seen the patient before, will never see them again, and have no way to know how what they did affected their patients. Some of my stories are about friends who went to emergency rooms and were, unnecessary surgery, and ended up chronically disabled with pain. And I don't think the people at urgent care know what happened. I don't know if they care. I think the most important thing I do in my office is I say, Joan, could you give Frankie a call, see how he's doing? You know, it's that simple. Mouth goes dry. So we have gone from being in charge of who we take care of, what we do, to being told that we need to be told what we can diagnose, how long, you know, to go into an EMR and have one of your choices come up green and the others not so green. And so being conditioned to push the right button that Epic wants me to push. I actually, over 20 years ago, adopted EMR technology, and this is when doctors were in charge of it. And most of the notes were freehand. They were very, very functional. Cost about $1,000 per physician to initiate, and I have seen each iteration, each new version of EMRs being less and less and less helpful. They eat up so much time that one of the reasons I'm in private practice is I'm my own boss, so other people are not my boss. So I still take notes in pencil. I don't have a computer in front of me, and I at the end of the encounter, I give this to the very nice, very smart woman who creates passable Epic notes. We now have, there is software available that will take these EMR notes and go through them and sift out the few things, the few nuggets that are there. When somebody sees a patient of mine in an emergency room or a specialist, it comes back with just pages and pages and pages of uselessness. And I have to read through to find the one or two things I want to know. And we used to use telephones. If I had somebody, like I remember this girl who was cutting herself, and I didn't, this was when cutting was new, and I called up, I said, Mike Jelnick, head of psychiatry, and he said, I'll see the patient, tomorrow or the next day. And I could call directly. You are no longer allowed to call a specialist. You have to refer them through Epic, and you have no control about who they see. And they don't, it's just the immediacy of a phone call to a patient or a fellow physician has been lost. I mean, and that was a safer way to do things. It was a much safer way to do things. So what do we do? In this instance, I think we should follow the lead of nurses, because nurses know what is safe and what is not safe, and administrators should not be telling nurses what constitutes safe nursing. And nurses, when they strike, they do it for patient safety. They don't do it for money. They don't do it for better benefits. They do it because what they're doing, what they're being told to do, is harmful to patients. So as much as I love universal health care and single payer and everything, I think we can take a much simpler metric, guideline, whatever you want to call it, and say things that hurt patients should not be part of medical care. And we have more science now, and we have the experience of COVID, where acutely in COVID, co-payments and deductibles were waived. So the clinicians would evaluate a patient without regard to their insurance status, without having to do that bookkeeping. And they see this patient, they would evaluate patients and take care of them. And even some of the documentation requirements were dropped. By doing that, it saved patients and their families hundreds of millions of dollars. It allowed for safer, quicker, better clinical care. Now that is being taken back. We were allowed to do telehealth for a while, which was very helpful. Now it is so much more difficult to do the documentation. I have a thing I have to hit whether my patient is in New Hampshire or not, you know, and it's just easier for me to just call the kid and say, what's going on? So again, we are forced by the ridiculous requirements to, you know, it makes it impossible to give away care the way we did to Anna Maria, who was that little girl who came to us with the note pinned to her chest. The first time a patient came to me and from another, they had been seeing, they were switching pediatricians over to me. I said, oh, that's very nice. What went wrong with your last pediatrician? Because I don't want to make the same mistakes. And they said, oh no, it was fine. It's just they're not on my insurer's panel. And the fact that somebody was coming to see me because of their insurance rather than some special care they wanted from me, which, you know, they were just coming because their insurance told them that if they came to me, care was free. If they went to their own doctor, it was going to cost the outrageous $20 a visit we were charging back then. So to go from being able to take care of patients based on their symptoms, and to go from being able to take a history, which is how you make 90% of your diagnosis, from going from a situation where you can actually do a physical exam to one where you are told you have to fill in your performance metrics, you have to make 2 out of 3 of these meetings to meet the citizenship requirement of our PPO. It just goes on and on. I was taught by my teachers who were, you know, who were powerhouses and had incredible personalities and incredible ways of taking care of patients. The guy who taught me about the physical exam, it was like the world stopped. And as he paid attention to this woman, I, you know, learned how to do that from him. The number of physical exams that are done today is just about 0 because you can hit a button and it says all normal. And if you remember, say, oh, there was a flow murmur, to go back and correct that is going to take you more than it would take you to take care of another patient. We used to take care of patients with them as the boss, because if we did not please them in the community, our reputation would just, and people wouldn't come see us. Patient was in charge. We were in charge of either passing this patient on to a specialist who, if they didn't please me because they didn't please the patient, or the hospital, I wasn't told I had to send people to Mass General. I could send them wherever I want, and I still can, but I get pressure. So we give you red carpet, referrals, and I swear these guys, they talk like thugs sometimes. They say, "Nice little practice you got here, Dr. Vonnegut, but you know, you're doing the horse and buggy stuff. You know, you look at the orthopedics. You know, they're no smarter than you." I said, "Okay." And they drive in better cars and everything, and it's all because of the insurance. This was before insurance took over pediatrics. And they said, "Here's the deal. We're going to give you, you know, people aren't going to come see you if they have to pay the $20. They'll come see you if it's free. And this new employer-based health thing is going to be really big, doc. And, you know, and we are going to give you double what you get for any given procedure and any given visit. Overhead goes up a little bit, but you know, you need a computer. We'll help you buy the computer." And, but you know, and I say, "Well, what if overhead goes up?" I said, "Don't worry, doc, do the math. If you're getting twice as much per visit and your overhead goes up even twice, you got twice as much income." So I'm used to dealing with teachers who can almost levitate a patient with a physical exam and who can take a history where the world is quiet, waiting to hear the person tell their truth about what's going on, to somebody who's telling me, "Don't worry about the overhead, doc." I said, how did this happen to my profession? And I get back to, so what do we do to reclaim the profession? And I say, follow the nurses. We don't want more money. We don't want, we're complete idiots that we've been bought for, shiny objects, and we've rolled over, oh, I'm going to get reimbursed just as much as partners will. Well, you have to do this and you have to do that. And now they are going to have virtual monitoring. So as I'm taking care of patients, they can see it on Epic. Oh, great news, great news. But we actually we have the science and the math to say co-payments and deductibles would have hurt patients and hurt the public health had they continued in COVID. We can also say they took, I think, 400 some odd vets, and their insurance had a period where they had co-payments, and they had a period where they didn't have co-payments, and mortality went up 34% when patients couldn't afford to take their medicines. I don't know, the idea that making our care more expensive to patients, the idea that we are somehow making false diagnoses and giving patients care they don't need is ridiculous, And I say, I want us to get back in charge. And if we can just insist on, just like if it's a new pill or a new operation or a new medical device, has to prove its worth before it becomes part of what we do. And if we say, okay, this value-based medical care, by the way, there's fine print in this, you're going to have to find some way to get the patients to tolerate it. And I remember the first days of HMOs where the patients had to be forced into those situations by their corporations who had a lower rate if they had younger patients. It goes on and on and on, but people were not happy. It was a badge of honor that the community health plan, I used to say no community, no plan. But we took care of them at Mass General, but we were fired because we brought too many patients in. And the only thing that insurer ever cared about was how cheap can you do this job? Quality was never mentioned. The fact that our senior residents were said, well, it sounds worrisome. I think you should come in and be checked out. That's not the right answer. And the fact that you can say, well, usually, a fever of 104 isn't going to kill a kid. Usually, febrile, and you can go on with all the usuallys, but our job is to make sure the not usuallys don't slip through. Usually, an ICU can have like 4 patients for a nurse and nothing bad happens, but the not usuallys happen, and they happen a lot, and that's what we went to medical school to learn how to take care of. And it was supposed to be us taking care of our patients' concerns, and how I think we are paid to do everything but take care of our patients' concerns. I was talking to somebody before and about the way we used to, before any money changed hands or whatever, you go to the waiting room, you see your patient, you walk them back, you do your own heights and weights and vital signs, and by the time you're in the room, you know what's going on. The patient knows they are getting taken care of. Instead of showing up, give it, let's make we need to see your card, we need to check this, we need to check that. And then they see, I love my medical assistants are truly wonderful, and they're the ones that do a lot of my notes. But by the time you get into the patient's room, and again, you're checking over, we've done your behavioral, do you feel safe in your, and on and on and on. By the time we've done that, the patient that really came there with a question, maybe just one, is depressed and think nobody really cares. So and these checklists. For a while, my younger practitioners have gone against me on this, but I did not allow computers in the room because I thought that the eye-to-eye contact told you an awful lot more than the nausea, vomiting, all the things you're supposed to check off. Anyway, what I would like is for this to turn into a community conversation about how we can get control of our profession, how we can truly take care of our patients. And it seems silly to have to write a letter that, Maggie Kerr still has no left leg, which I had to write every day, every year for a while. Taylor Diaz is still paralyzed, and he needs these, and while that's funny and silly, it is stealing time, money, and resources for clinical medicine, which is serious and which is what we learned in medical school. And we should not have administrators say, but if you do it, if we have more nurses in the ICU, we can't afford it and you won't have any hospital. A country that is spending $4 trillion on medical care for care that is half as good as the idea that we can't afford to fully staff an ICU with nurses. Why do we accept that? We shouldn't accept that. We can insist, and I think as a profession, we have rolled over and said, oh, please give me another. Again, it works like thugs. Oh, Dr. Vonnegut, you're really good. I think you're a really good doc. You went to Harvard and all that. So we're going to give you 20% more on every sick visit than the other people. I knew this was just a lie or whatever. So I said, but we didn't have a choice. The PPO says you are a whatever doctor and you are going to get enhanced reimbursement. A couple of years later, we've done the numbers, doc, and you're not really 20% better than the other doctors. So we're going to have to knock down, your sick visits by 20%, and your 99214s are all 99213s, and half your 99213s are going to be 99212s now, doc. We got to make ends meet, and they. And we shake in our boots and we say, please, please. And they say, okay, this time we won't do it. But doc, watch it. There really is this, watch it, doc, because we can come back and we can audit your books, And anyway, I want this to be something that all of us talk about. And I think the simple guideline of we took an oath to not hurt patients, and the things we are doing as administrative details, the way we are spending money and wasting time is hurting patients. And I don't think that is right, left, or blue or red. It's just, as human beings, we deserve health care that does not hurt us. And when you take somebody with a broken arm and they have co-payments and deductibles and they can't really afford care, and the amount of medical debt people are carrying is astounding. That is hurting the patient more than the broken arm. And, at Barnstable High, I broke my arm playing football. They took me to the emergency room. I don't think it cost $100 or whatever it cost. And had my parents not had the $100, the hospital wouldn't have chased them for the money. They would have just said, okay. And that's enough. Let's talk, among ourselves about what we think we can do. And as I say, I think the simple guideline should be, we should not go along with things that hurt patients. We should follow the example of the nurses, who have been much braver than we physicians have been. And we should speak up and tell the public that it is not safe to do things the way we're doing. It's essentially exactly the same thing, which is not taking care of people with pre-existing conditions, because the people with anyway, they're the ones that are hit by the co-payments and the deductibles and so we are doing the same thing, and all of these But healthcare delivery innovations do exactly the same thing. They exclude patients from care, they pay doctors and hospitals less, and they incentivize us by offering us insulting amounts of money to go along with their guidelines. And so far so we have lost 40% of our rural hospitals. That's infrastructure that's not coming back. We've lost 85% of community physicians and specialists that used to work around those hospitals, trying to find, as I said, 40 years ago, if I needed a gastroenterologist or what, I got on the phone. If I needed a psychiatrist, I got on the phone. My patients got care quickly, they got good care, and they called me back and said, don't worry, you're overreacting. Care is now different. And I think, I have the perspective of having been a primary care doctor for over 40 years. So people don't believe it, but we used to deliver care for $10, $15, and $20 a visit. Our overhead was 27%. I was able to pay back my student debt in 9 months. And that's true. And so if you do the math, the overhead per visit then was like around $5. The overhead for one of my visits now is over $100, mostly because of all the things I have to do to fix Epic, to fix my performance metrics, to fix this. Over half of our overhead in our office goes to useless stuff. And useless stuff isn't just useless. Useless stuff hurts patients. So that's it. So Dan will tell you, doesn't help him manage diabetes. In fact, it slows him down. I'll tell you, any pediatrician who is helped by the asthma guidelines shouldn't be practicing pediatrics. And I think most people will, if they look at it, they'll look at even the DRGs and the length of stays and all of these things where there have been, over the last 40 years, it's been a gold mine for administrators, and less money has gone into clinical care. The idea, I said I was going to stop and I will soon, but the doing, we're supposed to be able to do more with less. You can't go into a grocery store and say, I'm going to give you less money and you're going to give me more food. So the less we are doing, you can't do more clinical care with less money. You can't do more clinical care with fewer doctors. You can't do more clinical care with less education. And somehow, some way, the public and a lot of our profession has bought the notion that, we can get rid of low value care and But we've become so obsessed with the cost of care that we're ignoring the cost of not caring. We're ignoring the fact that insulin is cheaper than, or should be, than amputations and kidney failure and blindness, which is what happens when you don't take good care of diabetics. So we are all, and the other thing is we are all hurt. Our patients are hurt, doctors and nurses are hurt, and the general public is hurt. And all of this falderall that we put up with, it makes medical care unaffordable. And all the hospital closings, and you talk about the crisis in behavioral, which is very, very real. And so why do we keep eliminating hospital beds for kids? Again, is it usual for one of my patients to need a psychiatric hospitalization? No, it's not usual, but it happens. And that's what we're there for. We're there for the unusual things that still do happen. So anyway, if anybody wants to, thank you.
If anyone wants to ask questions.
Yeah. Or have ideas about what we could be doing to reclaim, I can tell you about pediatrics. I'm sure, Dan can tell you about internal medicine. Sheila can tell you about ICU nursing. And we all have different stories, and we all have, and I think there are ways where we can just say, I'm really, really sorry, but we can't put up with this anymore. And we're not striking for more money. That's not what we want or need. We need our patients to be safe. We need clinical care to have adequate supports. We need enough money. We need more to do more. I mean, you're going to tell a researcher, oh, we do more research, but we're going to give you less money. I mean, again, it's like a slogan you use to sell soap. We want you to get by, you can get more suds with less soap. It's just, I'm sorry, but that's literally what we've been told, they're doing more with less if we get rid of the low value care. Guess what? Anyway, our job, what we learned to do in medical school was to get rid of low value care, and we're doing a very good job of it. And there is no guideline that anybody has ever given us that has helped us do our job better. And we should be saying that. So
Dr. Vonnegut, I enjoyed it. It's a bit of a rant, and I enjoyed it entirely. But having said that, some of the ways out of this that are a little bit less drastic than trying to get the medical profession to turn to one great big union, which I think is a ways off. I wonder, and I'm in a way, this is sort of an apocryphal question. How do you think artificial intelligence will perhaps help the way out, help the way forward? Perhaps, for example, I understand that there are folks who are using artificial intelligence to construct their notes after they've been in there talking to the patient and so forth. That might allow more attention directed back at the patient and let the computers do the documentation.
Right. If it's controlled by and judged by physicians and patients, it's just like the EMR was it should have and could have made us much safer, more efficient, but it became a billing machine. And so if AI is harnessed to seek out and destroy low value patients and low value providers and low value hospitals, not so good. But if it's really, if AI is really used to help doctors the way EMR technology was supposed to be used to help us, then AI, I bring it on. Yeah, but I do think, well, here's another thing that I think the way we pay for medical care is about to go, is sort of like, it's sort of like a pyramid scheme where they have promised, yesterday they promised to pay for the healthcare today, which costs much, much more. And they're promising today to pay for the healthcare tomorrow. The insurance is not a cornucopia. It only can work if it sucks in enough money, currently about $20,000 per family. And once it can't suck in that amount of money, it's like being Bernie Madoff with your creditors are coming to you from the hospital. Says, I just did a heart transplant. And they say, sorry, doc, did you do your prior authorization? Have we done this? Have we done that? And so they'll be putting more and more hurdles in the way of getting paid. But we're on an exponential curve, and we can't suck in, more money either by taxes or by insurance or by employers. There's just, you are essentially taking money, not making investments in care, and then the bills keep going higher and higher, and the day of reckoning is going to come where healthcare, there's just, hospitals and doctors aren't going to be paid unless, and I'm not suggesting we all become a union. I suggest we become a little more vocal in our websites or whatever about why things cost as much as they do. I recognize that, a big union, much as it would be fun and bring back the juices of the 60s, it would be great fun, but it would fail. But I do think a more awareness within the profession, and people really will listen to doctors. I mean, I think we have lost a lot of our credibility because we, in fact, do act, when we are doing things that aren't in their best interests, or we don't have time to see them, or we say we're booking 9 months out or whatever. I understand why the public doesn't trust us. But if we started speaking up and say, for the good of the public health, for the good of bringing healthcare costs down, really doing that, this is, doctors suggest and nurses suggest that we not be forced to do administrative stuff that hurts patients and doesn't help them. So I think we could, the picket signs and all that would be great fun. Last time we picketed to stop a deer hunt in the Blue Hills, but didn't work. I felt like old times not here, because there hadn't been any hunting in this beautiful 6,000 acres for over 100 years. But actually, I was there, just said not here, and somebody came by in a pickup truck and went, So I know, I know that I'm not advocating a union per se. I am advocating, if you are in a spot where your patients are being hurt by an unnecessary administrative thing, you can write an op-ed, we can be more public, because it looks to, if we say, when the nurses say we need more nurses in the ICU, if we say, we're sorry, you won't have a hospital, if we have to pay them, it doesn't look to the public like we're on their side. Yes, sir. That's it. That's all I can do. Anything, all of the above. And I have sent out, how many op-eds have I sent out that haven't been published? I mean, she tells me to stop sometimes. She'll look at me across the room, like at a fundraiser for something or whatever, and she'll go, "Oh, somebody talk to him about insurance." So, yeah, all of the above. Anything you can do, being honest with your patients, being honest with your fellow doctors, being honest, letting people know how we feel, which is that that there is no evidence that co-payments help. There's quite a bit of evidence that they actually hurt. We got rid of them during COVID. In what situation are co-payments helpful? And if they're not helpful, what are we doing to not, attack them the same way we attack polio or any other disease? I think, yes. She's my wife. She has a good loud voice.
So, so I do have the mic, so just make a quick comment, then I'll pass the mic. So I'm a pediatrician as well for past 30 years. And so my concern is, and I'm commenting about the PI, my concern is that, and I think the horse is already out of the barn at this point. I think becoming more reliant on more technology, I don't think that's the direction that we should go in. I think that, medicine was, even with telehealth, I talk to people all the time. It's like, listen, medicine is not supposed to be practiced on a computer. Like, what kind of physical exam can you do on a computer? You cannot lay your hands on the patient. So all those things that we learned, our skills over time, are completely gone. So, but unfortunately, I don't think that there's a whole lot of, impetus to. I think a lot of the dollars in medicine is actually going towards more technology, which I think is really taking away from the patient. I mean, I see I'm in a couple of situations right now, you know, we use Epic as well. I walk into the exam room, there's this huge computer screen. And the the chairs are on the other side of the computer screen. Like, what kind of a design is that? Right? And the other thing that I'm having trouble with is the way that they keep track of our, you know, how long you're in the room is the first thing you have to do is log in the computer. And I had been at the place that I'm at, and I had these IT guys tell me all the time, like, you know, why do your numbers look so bad? Like, why are you always running behind? And that's because when I walk into the room, I try to talk to the patient and forget to log into the computer. So my real concern is that this over-reliance on technology, it's not helping us. But I don't really know any way to, I really think it's like too far gone at this point. I don't see it going back. And I think if there's any way that people think that we could do that, that would be my suggestion.
Yeah.
We become much less reliant on the computer.
And I think we could, and there's studies show that if you the hospitals go way down, you save a ton of money. So again, there are studies that say if you give patients access to primary care, medical care gets better and it pays for itself. And yeah, technology is, you know, it could have helped. It hasn't helped. It won't help. And that's why it's sort of like why I became my own boss and why my office is about to be bulldozed and turned into $1 million condos. But I do think, you know, and I do, I remember my teachers and their idealism and their energy and what they would say if they were, you know, they roll over in their graves. And, yeah, physical exams are virtually not done anymore. And yeah, those same people who told you, told me too, if you really want this thing to work, doc, you got to see at least 6 patients an hour. There's no other way. Yeah. It is possible if doctors are in charge of how they are doing things. It was a bad flu season, I don't know, 20 some odd years ago, where I saw 65 patients. But the way I did it was flu, pneumonia, flu. But, you know, the patients were paying $10 a visit, and I was in charge of how I practiced medicine. I love going to Haiti and Honduras because there's nobody telling me what to do. And when doctors trained to ask for help when we need it. And I would love it if asthma, you know, if the notice is your patient hasn't refilled their inhaler, if that actually helped me. I say, you know, my asthma plan for you, Jack, is to tell your mother when you're wheezing, please, you know, or my worst asthmatic won't stop vaping. What am I, you know, but I mean, these are real things that we know how to deal with. And, you know, it's absurd that I think we will end up, and I have a good friend, Nancy Oriole, who is dean at Harvard, who started the family van, which just goes around and provides free medical care. Jim O'Connell at Boston Healthcare for the Homeless. He does amazing work. And again, he is not told what to do. He does what he knows how to do it as a good physician. And he trains his staff. And it works. Medical care is an investment. We are an investment. My culture and family and community gave me the opportunity to go to medical school. So I owe it to them. I don't owe it to Epic or any of that. But I do think there are things, if we keep our eyes open for opportunities, and I think the biggest thing we can do is educate our patients as to why their bills are so high, educate our patients as to things could be better, educate people as like we go to Haiti and Honduras and we give away care, and you know, I don't care what comes at you at Haiti or Honduras, there's no burnout. and burnout is these ideas that you need more balance, work-life balance. And if you spent more time playing ping pong with your wife, you wouldn't be burned out. And they have a morning yoga class that's, and the burnout is completely about being educated to be a professional and then not being allowed to be a professional. Because a professional addresses the needs of their client or patient, and that's what they do, And I sometimes ask students, so what do you do after you have taken care of your patient's needs? And I say, nothing, you're done. Use your voice.
I'm good. After the visit, when her O2 stat was like 88, she was 91. They weren't sure if she had pneumonia. She's coughing like a banshee, along with, and this woman walked her credit card. I was just like, what? Really? Like, you need her money now? And I was like, that's in the hallway in the
Right. And hospital emergency rooms did not used to be war zones. Yeah. Mm-hmm. Yeah, right. There is so much need, and we're not given the resources or the personnel or money. We're not being supported to take.
like, you're a member of
No. Right. Hey. Because if they did, they wouldn't get their enhanced reimbursement there. Yes.
This was just a wonderful talk. And I was a program director in my earlier days, but what you've said is all spot on. One of the comments I'd also make about the technology is that the residents that I've worked with over all these years have relied ever more on the technology without thinking at all. So they get all these incidental lomas that they then have to follow, which had nothing to do with what brought the patient into the hospital in the first place. And it's actually scary because they don't think anymore. It's let me present this 51-year-old man with abdominal pain, and his CT showed, without any other information. Drove me crazy for a lot of years, and I worked hard on trying to write that, but it's very difficult. Some of it simply because of constraint of time. They don't have time to think about it, and therefore they just get the testing done. Your comments on burnout again are spot on, as they were in your book. And I think it's good to know that in the early 70s, the term burnout was just created at that time. We were working incredibly hard. We were tired, but we weren't burned out. And we weren't burned out for the very reasons that you're describing, because it wasn't a bunch of spreadsheet guys that were chasing us around.
We were learning how to be doctors.
We were doing good.
Yeah. And working over 100 hours a week, my residents, my fellow residents and we had a rock and roll band. I don't think anybody I don't think as a group of interns or residents who can get together and we say, if we could practice, we'd be wicked good, we played at change parties and everything else. We had the time and energy to have a rock band.
So I'm married to a primary care physician, Ken Crowman, and about 10 years ago, there was an article, maybe 15, article in JAMA that was called Shirts versus Skins. Shirts versus Skins. And this had to do with physicians using less technology to diagnose the patient and looking at the patient in the eye and thinking. Right. And I think that's what Dr. Popkin was just talking about also, is maybe changes need to be made as far as going back to the old way of teaching doctors, residents to be listening to the right. patient more closely and start thinking about that 90% of, doing the physical and what right. could go wrong, even though you have a lot of technology at your fingertips. Do you need it all?
One of my favorite lines in the book is, if you can just shut up and let the patient tell you what's wrong, unfortunately, there is no ICD-9 code or procedure code for shutting up. But yeah, I mean, our patients, they want us to get it right. They don't like it when we're sitting there clicking. I remember my psychiatrist, once I was going to see him and there was a new questionnaire about whether or not I felt safe in my relationship. And I said, well, Barb, she could beat the hell out of me if she wanted to, but she doesn't. But these things just, there must be some way for us to not put up with this nonsense and get back to meeting our patients' needs, not Epic's needs or whatever. And yeah, I had a lot of hope and faith in electronic, and digitalizing records, partly because of my handwriting and spelling. I knew that this was a better way to go, but it got completely corrupted. And again, it was money versus mission, and money won. Yes, Jill. Right. Money. I mean, it really, it makes no sense, but they have this notion that medical care costs too much. So if we have less medical care, it will be better. I mean, again, it's the soap ad, more suds with less soap. It's wrong. And it is horrible. Right. Exactly. Yeah, well, you only have to hit one button and it'll give you lungs clear, no murmur. You can do a whole physical with one click. That's exactly what they do. I had a friend and also a primary care doctor who would fill out his electronic record notes before seeing the patient. It's bad, but he was a great doctor. And then he had time to spend with it and he would amend, but he knew the patients. He had a sense of what was going to, but he would fill out his whole note before he saw the patient. And that was just, right. 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 I wrote a note for college, a highly recruited, excellent hockey player, Brendan O'Brien. I had to write a note that he didn't have sickle cell anemia. And I said that I had given him a test and he didn't have sickle cell anemia. I mean, again, these are mandated things. And like one visit, I was asked if I felt safe in my relationship, and never again. But I just, but it's more than incompetent. It is what makes them money because it allows them to close hospitals. It allows them to not pay physicians enough, especially somebody who is not like me getting enhanced reimbursement because I'm part of, you know, the wonderful MG. Yes.
That's just like saying, like, what you have to do as opposed to, Frankie's not that.
Right. Frankie has had many problems, but his mother brought him into me because he was vomiting every week. He would throw up, and I said, "What's up, Frankie?" He says, "She makes me eat eggplant, and it's slimy, and every time she makes me eat eggplant, I throw up." I said, "See, I went to medical school, and what are we going to do here? Bear with me." Here's what we're going to try. No eggplant for 2 weeks. We'll see if, you know, and, you know, but again, I love the fact that I know my patients, and I know that 3 years later, his teachers were worrying he had ADHD. And I told Frankie, just pretend you're interested in what the patient, and the mother will stop sending these stupid notes home to your mother. Everybody will happy. Just look at her as if you're paying attention, Frankie. So, but that's, you know, I have learned these things from my patients, and you know, my patients allow me to take care of them because I went to medical school and I did the residency. That's all very, very intensive work that the community put into having medical care. And now lots of people, and I think part of the reason, you know, huge parts of the country are so angry is they have no medical care. You know, if they're hurt badly enough, they get medevac, but most of the Midwest, most of rural America, they've lost their hospitals. They've lost their community physicians, and that's infrastructure that's not coming back. But every time a hospital closes or an office gets bulldozed or whatever, that's money the insurers, payers don't have to pay because there's no care to pay for. But I really want to think that things will change for the better and that we can help things change for the better. And I think partly by talking to each other about it and our patients and just having a sense of awareness. And as I say, I think my op-eds, I think I'm 2 or 3 for 100 or so, but you got to try, you know? Yes. Yeah. Yeah. Mm-hmm. Right. 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 You can. And the capitation here is probably like in my practice is coming out of Mass Health. And the way you make your metrics is you find your sickest patients and you kick them out and have them go get care elsewhere. And the capitate, I mean, it's already true, and it's more and more true that I get paid twice as much to take care of a well-off patient than I get paid to take care of a poor patient. And the poor patients are much more likely to have complicated problems that take time, that make it very, very hard for me to make my 6 patients an hour. But there must be some way where we don't just lie down and take this. Because again, capitation could be a good idea. HMOs could have been a good idea. Electronic medical records could have been a good idea, but they've all been weaponized against physicians and patients. And NPs. And RNs. Okay. Oh, please do. Please do. Yes. Right. Right. Mhm. Right. Mhm. Right. Mhm. Right. 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 I know. Remember Dr. Cafeterias? We had the little room off to the side where we did consults. And at the time I thought, oh, there's something wrong with having a special room for doctors to have lunch, but it was good for us. Yeah. Yes, there is. Right. Mhm. 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 And if we can go to Honduras and Haiti, why can't we go, you know, uh, to Los Angeles? No, you know, so I do think I'm serious about that. We could act like Jim O'Connell and Nancy Oriole and the family van and, and be, you know, medicine without borders in our own country where we have, you know, where there's no medical care. Again, they're little answers. I don't think we're going to find a big whole answer, but, I was talking to, a minister of a black church, and I said, I bet you two doctors with stethoscopes and could come and take blood pressure, and that little touch would make a difference for your patients. You know, and so again, it's not. I wish, you know, I wish. You know, I think, you know, these billionaires, there didn't used to be billionaires. They could wipe out homelessness, you know, and the public health benefits of not having hepatitis A, B, C, untreated, you know, HIV, untreated tuberculosis, to have that living under our bridges, and it's going to make it into the gated communities. I mean, it's ridiculous. And the untreated mental illness is the same deal. So, I mean, there is a threat from not giving not treating treatable diseases. And I think, you know. No, but there is no performance metric or dashboard that'll make us do it better. We will self-correct, and eventually, you know, I want people who went to medical school to tell me where I'm wrong. I do not like looking on my, I'm number 97 in my practice for my asthma composite score. You know, mostly because I forgot to delete the diagnosis of the kids who didn't have asthma. My numbers have gotten better since. Thank you.
So go out and have some more to eat, then buy the book, and we'll have a book discussion in a month. I don't.